Hi folks, this is Dr. Rob CYWES. I am the carb addiction doc, and I've recently had a request from the Nutrition Network, which is a fabulous South African-based organization that trains a lot of people in the ketogenic metabolic health space. And in fact, I prefer the word metabolic health space now. It is led by Tim Noakes, who's the emeritus professor, a huge mentor for me. But one of the key things, because of this rapidly evolving science of metabolic health and a lot of pharma input, a lot of input from a variety of different people who have different agendas, is to really speak about the ethics, the ethical component of the advice we health practitioners give. And as such, the Nutrition Network has asked me to put my opinion out there as a pediatric surgeon, as a metabolic health specialist, regarding my thoughts on the current status, is now August of 2024, the current status of metabolic health management in children. Well, first and foremost, and these are my opinions. You can argue with them. You can embrace them. My job is not to be right or wrong. My job is to help you to think in an ethical manner about what I'm going to talk about. And you can disagree, you can agree. There's no consensus. But thinking laterally, getting in my head, and then comparing that to your own thoughts. So the first thing I'm going to refer you to, and I will attach a link to this, and that is a link to a video that I just recently did on, it's kind of where I am just so saddened, but it's a link to a video I did on the 4 forms of children. And this ethical video is going to be primarily about children, the 4 forms of children that we currently see based on nutrition. And the 4 forms of children we see based on erroneous and dysfunctional nutrition. The obvious ones are the obese children, very visible. The second ones, which are the most invisible, are the skinny children who appear to function fairly normally, maybe a little ADHD, maybe a little bit hyperactive. They look normal, they look healthy, but when you touch them, there's no muscle. They're skinny and they don't have muscle integrity. And that muscle integrity not just affects their bodies, but it also affects their brains and the mechanism by which they manage emotional need. Those are high carbohydrate eating kids, as are the obesogenic folk, the obese kids, just different genetic expressions of the same problem, which is a massive, massive high volume of carbohydrate in their diet by percentage, not just by quantity, and also a deficit of adequate fat, and protein. And then the worst tragedy in terms of metabolic dysfunction, and I don't mean that in a judgmental way, but the worst metabolic dysfunction from diet, whether they're obese or whether they're skinny, are kids whose brain didn't develop properly. And those are the kids with profound ADHD and autism spectrum disorder. And I'm unemotive. You see, the problem with autism spectrum disorder, it's a behavioral diagnosis. But I really look at autism spectrum disorder as a nutritional disease that is due to excessive carbohydrates, excessive insulin response in mother and child, and a lack of adequate fat for the growing brain that is primarily made of fat. So autism spectrum disorder is, of all the spectrum of metabolic health issues in children, the most permanent because it affects the entire rest of that child's life. By the age of 5, their brain is developed. And then the 4th child is what I would call the healthy child. The child that eats a healthy dose of fat, a healthy dose of protein, and a very, very limited amount of carbohydrate, where carbohydrates are the lowest percentage of food that child eats, contrary to the popular belief of what is healthy to eat. When we look at our physiology, we look at our biology, and Prof. Tim Noakes was my physiology teacher. He taught me this. So if you disagree with me, take it up with him. But no, I'm an acolyte of this, and that healthy child whose brain structure is normal, not super normal, but the white matter of the brain, the gray matter of the brain connects and it's doing itself justice so that they're not super better, but they're as good as genetically primed they can possibly be. so that you've maximized your genetic potential rather than reduced your genetic potential because you didn't give your brain the right substrate. But also from their body build perspective, those kids are not going to be taller because they ate well. They're not going to be more muscular than they should have been. But we've forgotten what normal height and normal size looks like. Those kids will achieve their genetic height. They won't be super taller, but their stature won't be diminished because they ate garbage. Their muscle development will be normal. It won't be super normal, but it'll be normal. When you hold their arms, you'll feel their muscles. You hold their legs, you'll feel their muscles because they've given their bodies the right substrate to develop that based upon maximizing their genetic potential. You can't go above genetic potential. So if you're short or tall, you don't be less tall, less short, less muscular than you were supposed to be genetically. And those are the 4 categories of children. So I'm going to use that foundation as a basis to discuss the ethical considerations, both in terms of promoting the optimal health for a growing child, as well as if your child has one of those other issues, what are the most relevant, best ways to improve or negate or reverse or stop those things from continuing in this child's life. So the first preventive strategy for the pregnant mother as well as for the developing growing child is to have 3 dominant elements in their diet. Number one, and we've demonized this, is fat and primarily saturated fat, non-seed oil fat in their diet. Whether it's animal fat, whether it's coconut oil, avocado oil, olive oil, but having healthy fat, particularly for the growing brain, a very high dose of 3 omega fatty acids to counter the effect of the 6 pro-inflammatory omega fatty acids, which are the only 2 essential fats. So having a dominant fat component of their diet, preferably supplemented or consumed as fish and seafood with a high quantity of 3 omega fatty acids. That's the first thing. Fat is the dominant source of energy. Fat won't make these kids fat. It won't cause damage to their blood vessels, quite the opposite. The second thing is an adequate amount of protein, somewhere around 20 to 25%. You don't need super high levels of protein, but you want adequate protein, slightly higher if you're not eating a lot of carbohydrates because your blood sugar then comes from protein as well as the structural growth. But fat and protein are the 2 primary macros. Sugar and starch, relatively irrelevant. The primary role of sugar and starch in the diet, ideally as glucose and galactose, which we find in milk, is to trigger insulin, which is your anabolic hormone, not as a primary sugar substrate for the body. So the ethics here are that the child should have some carbohydrate in their diet, whether that comes in the form of milk or whether it comes in the form of some fruit or starches, but never, if you can help it, manufactured foods. Nothing in a bag or a package that was manufactured in a factory. Preferably something that comes from an animal or a plant directly. So some sugar and starch, but probably around 10 to 15%. Dominant in a growing child should be fat and proteins, your macros, with carbohydrates primarily being there to trigger insulin, to trigger the anabolic hormones episodically. The second thing is meal frequency. A snack is primarily an emotional event or an event to combat postprandial hypoglycemia, where your blood sugar is going in a sawtooth fashion because of the amount of carbohydrates you're eating. If you're on a high-fat protein diet, blood sugar is relatively flat. The child does not need to eat that often. And also adding salt to the food is also important. Now, the third component of the diet to optimize preventive strategies, and this counters all the noise from dietitians and government agencies, is to prioritize micronutrients in the diet. And this is where there's a lot of conflict. But the first concept to understand, and think this one through, I'm 60 years old right now. Yeah, I'm 60. Okay? Almost none of the fruits and vegetables that we currently eat existed in their current form when I was born 60 years ago. So while plants and vegetables and fruit may be enjoyable in the diet, they've been hybridized to last longer, to be more disease resistant, and to be higher in carbohydrate level. They have not been hybridized. They have not been hybridized to increase micronutrient availability. Quite the opposite. And especially when they're grown on the same piece of land commercially, they've leached a lot of those micronutrients out of the soil and they're not being replenished. Because we focus more on disease rather than on nutrient repletion in our food. So the plants are relatively deficient in adequate micronutrients. So for a growing child, micronutrients should come primarily from the animal kingdom. And whether it's renewable or permanent sources of animal micronutrients, either way, the child should be exposed to these in a dominant way. The first one is milk, dairy, milk, cheese, butter, yogurt. Dairy is an excellent form of everything. And if you think about it, no matter how much you want to argue against dairy, no mammal can exist without dairy, especially in the first 4 months of their lives. And dairy should remain a very important component of a child's life from a macro and a micronutrient perspective. And in fact, if you break down breast milk into its individual components and you remove the bias of what's healthy and unhealthy for us, breast milk as a foundational resource for a growing child in terms of its constituents is about as healthy as you can possibly get. When you look at the fat, the protein, the carbohydrates, you look at the micronutrients in there, you look at the salt, you look at the cholesterol, you look at all of those aspects. The only deterrent from breast milk is our erroneously held biases. But basically, if you have a bias against the components of breast milk, you are telling God and nature that they're wrong. And for a growing child, we can debate it for adults, but for a growing child, that nutrient component, macro and micro, is about as essential as you can get. So dairy, if the child can tolerate, is one of the healthiest things you can get in. Secondly, eggs. Eggs are one of the healthiest components of macro and micronutrients in the right proportion. The major things that eggs are missing is vitamin C and calcium, and you can make the calcium up with your dairy. The third one, which most kids are not going to eat, but which, if you start them out eating it, is very, very valuable as a micronutrient source, especially metabolically, is liver. Other organs less important, but liver and maybe some kidneys. And if they eat that from time to time, I know the U factor comes in, but if you raise them with it, it's not too bad. And most cultures have liver as part of their promoted feeding. If you think about it, ancient cultures. And then the final one is fish and seafood. And especially your smaller fish, your sardines, your oysters, your clams, your mussels, your shrimp, they have huge nutrient potential, bang for buck, very, very good, and also come with a lot of 3-omega fatty acids. And by the way, fish and seafood is the least adulterated, genetically modified of any food that we can eat. Even farmed fish, they fed some things that may not be appropriate, but they are the least genetically altered. The most genetically altered are our vegetables and fruits and plants. And obviously the manufactured foods are not even genetically altered, they're just crap. Then the animals have been genetically modified to a certain extent, but much slower. And the least genetically modified are fish and seafood. So from a foundational dietary perspective, that is logical. It isn't even science. It is logical if you go back to nature. And aberrations of that, or those types of foods, did not cause the obesity, the skinniness, or the ASD, the autism spectrum disorder that we see so prevalent. In the US, 1 in 20 kids has autism spectrum disorder in 2024. So the foundation of a healthy nutrition, but we have to overcome our erroneous instinctive biases to get our kids eating real food again in the right proportion. Now, that is going to prevent both the pregnant mother and the growing child from developing the majority of the metabolic diseases. Once a child already has obesity, that skinniness, that underdeveloped skinniness, autism spectrum disorder, there are different strategies that we use. More and more so, those diseases are complicated by what I'm going to refer to as a substance abuse disorder. Eating and drinking patterns, especially as we as parents have fostered this, have shifted away from primarily being related to the nutrition of food toward more and more using eating and drinking for its emotion management role. And kids' desires, when they desire certain foods and they refuse to eat certain foods, are primarily predicated by and reinforced by the emotional management, the emotional triggering, the endorphin triggering of certain types of foods, typically high in carbohydrates, high in salt, and carbohydrates with fat, which don't occur naturally, except maybe in an avocado. But that combination, that salt, fat, carbohydrate combination of manufactured foods is incredibly powerful as a drug. And these kids at a very early age have shifted away from primarily eating food for its nutritional value toward eating and drinking primarily for its emotional value. And their emotion management systems are dependent on the highs and lows produced by sugar. And as a consequence of that, these kids have developed ADD, ADHD, stimming behavior. So while autism spectrum disorder is a structure of the brain disorder, it is also a behavioral disorder. And a lot of those skinny kids have hyperactivity, inability to focus, as do the obese kids, because what they're seeking out is emotion management from their diet, not nutrition. And it's not their fault. We parents have created that. Here's a treat. Here's something fun. Oh, I'm busy on the phone. Eat some candy. Here's some ice cream. Shut up. And usually it goes together with a screen nowadays. So we as parents have abused that shift to giving our kids manufactured carbohydrates as a control device, as an emotion management device. So we've got to understand that. And we've got to understand that these kids need as much evolution and development of healthier effort-based emotion management systems than looking at carbohydrates as a drug. Carbohydrates have no nutritional value, very limited nutritional value. They're primarily using as an endorphin resource. And the kids build a lifetime of emotion management on this that eventually leads to metabolic dysfunction. Now, how do you reduce this? Let's take each category. So the first one is helping that child to develop a more effective, diverse emotion management system that replaces the fridge and the pantry as a surrogate. Whether that is something creative, whether it is something that involves human connection, whether it is something that involves physical activity, which is a very powerful endorphin activator, whether it is something that involves spirituality or meditation, and certainly healthy sleep. I call that CHESS, C-H-E-S-S, creative arts, human connection, exercise, spirituality, meditation, and sleep. If you can, as a foundation, spend time, and that's the most costly thing. Spend time with the child, engaging in the child, becoming interested in, falling in love with, and developing chess as a foundational emotion management system to replace the fridge and the pantry at a foundational level. That therapy is far more important. But what do we surrogate to? We surrogate to mind-altering medications, amphetamines, Ritalin, Concerta, Lamictal. We use antidepressants. Kids are being treated for the sugar addiction with mind-altering drugs that affect ADD, ADHD, that is basically a wet blanket on these kids' emotion management systems. Well, how the hell can they develop a healthy system? So understanding that there might be a role for drugs, but as an ancillary to therapy, to parental change. That's a foundation. Now, metabolically, the next leap, so let's talk about the obese child. The first thing that people turn to is some sort of calorie restrictive diet where the child is miserable. And any child can do a diet for a little while, but pretty quickly They get angry, they get psychologically barraged with that, and they get very, very upset, and it leaves a huge psychological stigma on those kids. It erodes their self-esteem, their self-confidence, their self-respect, their sense of self is in the toilet. They're the fat kid. And that is an awful psychological place to be. And by the time they're teenagers, they are experts at failing diets. Diets do not work. Diets do not work. Diets do not work to change the cause of obesity. And diets are unsustainable because it's something you do to lose weight, but you don't change why you gained the weight in the first place. So stay away from diets, but slowly alter the eating pattern and the eating quality, the food quality of those children. Removal and replacement is far important than caloric restriction or specific elimination. The second thing that we jump to, which is the quick, easy fix, especially for adolescents, morbidly obese adolescents, I will agree that the quickest, fastest way to get a child to lose weight is surgery. Bariatric surgery. And bariatric surgery is the most powerful form of weight loss, the most important diet. And there is a role for bariatric surgery in a child whose life or body is threatened by the excess weight. So, for example, a lot of kids will have slipped upper femoral SUFI, slipped upper femoral epiphyses. They may have knee ligament tendon issues. They already may have gallstone disease. They may have diabetes. They may have sleep apnea. All of those things are reasons to rapidly get that child to lose weight. And yes, traditionally, surgery has been the go-to. However, in 2024, surgery should still be on the table, but it should be extremely rarely used. Firstly, very rarely used, and never in isolation, always in conjunction with all other modalities. So it should be a multimodal approach. Starting with a change in diet, starting with chess, change in emotion management, starting with a family, and then using certain medications, which we'll talk about in a second, and the last resort will be surgery. And when it comes to surgery, there are several different forms that can take. I think what's no longer relevant, although it's no longer relevant because it was poorly used, are lap bands. And while I'm a huge proponent of lap band, let's remove that one from the equation because nobody's out there going to be managing the patient together with band. There are intragastric balloons that may work well. Take that off the table. It's transient. They aren't worth the misery. And I've done lots of balloons. And in my own practice, I think they have value, but for the most part, the generic bariatric surgery practice, bands and balloons no longer on the table. The two surgeries that are the most effective in terms of weight loss, but one very unsafe and one very safe, one that negatively impacts on the child for the rest of their life, the other one that doesn't. The gastric bypass, the duodenal switch, and any surgery that rearranges the child's intestines, that creates metabolic malabsorption, where you cannot absorb the food. Any bypass type operation, be it a duodenal switch or a gastric bypass, is an awful, awful, awful surgery that is negatively going to impact the child's entire life. And while it may get them to lose weight, the trade-off is metabolic misery in a child who's developing to now start metabolically decaying. And yes, the results are beautiful for a year or two because you've lost the weight. But if you think about the next 80, 90 years of that child's life, it is an awful surgery, and in my opinion, should never, ever, ever be done in a child or in a human being under the age of 25. You've done the child a disservice. And a gastric bypass or duodenal switch can be an end-stage surgery after all others have failed, including the surgery I'm going to talk about next, which is a good, well-performed laparoscopic sleeve gastrectomy. And a sleeve gastrectomy is primarily a restrictive operation, not a malabsorptive operation. The child absorbs, or the person will absorb what they eat, but it has to be properly done. It has to give that negative disincentive to overeating, But it should go along with an entire system of helping the child to understand and change why they gained the weight in the first place. So, in my opinion, the only operation that should be offered to children these days in 2024 is a sleeve gastrectomy as a primary surgery. And always the sleeve gastrectomy should come with a hiatal hernia repair or tightening of the crura. And it should be long, and it should go around the corner, and it should not be too tight. It should be wide enough that the child can eat, but long enough that the food takes a very long time to get through, and there should be no sump pouch. And as part of that, the child should be educated not to lose weight, but to address their addiction to carbohydrates and to change their eating pattern. And that should resound in the whole family. Now let's work back from that, because extremely few children in the modern era, and certainly over the next decade, are going to warrant that. So, the next thing to talk about. Every child, every obese child, and in fact every skinny child, if you are interested in making a change, should be given a CGM, a continuous glucose monitor. Simple device they can wear on their arms. All kids that have diabetes, type 1 diabetes, are going to have CGMs. So it's in current use for diabetes, type 1 diabetes management, and has revolutionized the management of type 1 diabetes to a certain extent. Every child should be given a CGM and should be educated about how to read the CGM. Every child over the age of 10 pretty much has a cell phone. Every 10-year-old child or older is more sophisticated on a cell phone than I am. So give them the CGM as a biofeedback device, as a way to tell what eating is doing to them. And then in the privacy of their own mind, of their own system, without other people looking over their shoulders, that can be monitored, that can be used as a self-directed way that is empowering instead of debilitating psychologically. So CGMs are probably the single most important weapon you can arm your child with. And the biofeedback, if they're properly educated about what makes that go up and what makes it go down, and when it's healthy, when it's unhealthy, is the best strategy you can have for that child in the privacy of their own life to make changes where nobody else needs to know about it. But that education is very important. Secondly, together with the CGM, before you even think about surgery, there are several drugs on the market right now that very, very specifically, in a very healthy way, treat insulin resistance. And those are the incretin medications, the primary one being GLP-1 agonists, and then also GIP, gastrointestinal peptide, which prolongs the life of or glucose-like peptide, which prolongs the GLP-1 efficacy. So either GLP-1 medications by themselves, the classics are Ozempic and Wegovy, or GLP-1 GIP combinations like Mounjaro and Zepbound, and then eventually in the next few years, we're going to have the master drug, which is called GGG, retatrutide, being produced by Eli Lilly in clinical trials. That combination of medications, which specifically targets and treats insulin resistance that comes from their relationship with carbohydrates. If that child, that adolescent was an alcoholic, you might want to think about using antabuse. If that adolescent was a heroin user, you'd use Narcan and maybe methadone. Chantix, if the child was a smoker and you were trying to get it to stop. Why not use the GLP-1s in exactly the same way? There's no physician that will deprive an alcoholic, a smoking, a vaping, or a heroin-using child from those drugs that are disincentives. Well, why are we arguing about GLP-1s? GLP-1s are the safest, most effective drugs to help to reduce insulin resistance and metabolic disease, whether that's obesity or the skinniness of too much carbohydrate. So it works in both classes, and also very, very helpful for the autistic kid to calm them down, to reduce the stimming, to reduce the ADD and the ADHD. So the GLP-1s are incredibly effective and incredibly safe. Yeah, but what about all the side effects? Now let's look at the ethics of the side effects. GLP-1s are associated with a number of very serious side effects, but they are not causative of those side effects. So let's break this down. GLP-1 is a naturally occurring incretin. GLP-1 is the primary hormone, forget about drug, hormone in the human body that triggers gas bloat, that triggers irritable bowel syndrome, and that triggers acid reflux in response to carbohydrate load. If you eat adequate protein together with fat, you don't get the muscle wasting. You can actually, paradoxically, by eating less, grow muscles, particularly if you are physically active. And I would push physical activity as part of this. Not to lose weight, but to enhance as an endorphin effect and protect the human body. Secondly, if you're not eating carbohydrates and the GLP-1s are a specific disincentive to eating carbohydrates, the paradox is that your reflux, your gas bloat, and your irritable bowel syndrome goes away. And if you're only pooping every 2 or 3 days, that's okay. That's not constipation. So the side effects of the GLP-1s are actually side effects of the diet, not the drug itself. Drug's just exposing that. The only specific, direct, currently acknowledged true side effect of high levels of GLP-1 is pancreatitis. And if you never ever dose to the highest levels, you reduce that risk of pancreatitis. So while pancreatitis is a real problem caused by GLP-1s, at lower doses or at intermediate doses, you're going to be safer. Not perfect, but really safe. Secondly, obviously do a screening for MEN. Medullary cancer does occur. That's a hard contraindication to GLP-1s. But that's part of the medical history. But the GLP-1s have ancillary focus issues. They reduce the risk of all, and I know these are not yet quantified, but all forms of metabolic disease are improved by GLP-1s. Why not have those as an anchor drug together with a transformation in the diet? You have to overcome, as a practitioner, your own cognitive dissonance that fat is bad for these kids, that they need carbohydrates. And the biggest problem with obesity, skinny kids, and autism spectrum disorder is not the children, it's the cognitive dissonance. The beliefs, the erroneous beliefs of the practitioners and as they tell the parents, of the parents, that these things are a problem. And as from an ethical perspective, I believe that the current dietary recommendations are a prominent form of malpractice. And depriving a child under managed circumstances of GLP-1 and putting them on Concerta or ADHD or doing or Adderall or doing surgery on them is also bordering on malpractice. There's your ethical soup. Because we understand and we know without cognitive dissonance the truth about human physiology, the truth about growth and development, and we have altered that away from the way nature intended by our biases. And we as practitioners ethically are obligated to confront our biases of what is truly healthy for these kids. Because clearly there's a massive discrepancy with what you're telling the kids is healthy for them and what is actually happening. And it's not because the kids and the families are not following your advice. It is because your advice is unethical and plain wrong in natural physiology. So there's the biggest ethical dilemma. So from an ethical perspective, it is, in my opinion, an obligation to understand what that child needs and foster a healthy diet, foster a healthy emotion management system by teaching the parents and helping kids to develop that. Those are the two foundational priorities. If the kid already has a problem, you can use certain medications, but also certain mental health medications. But in conjunction with that, use the GLP-1s that have profound improvements in mental health and reserve surgery for the very, very last. And all because they're under 18 and these drugs haven't been tested in kids. They've been tested in humans. And while I'm going to argue with you that a child is not necessarily a baby adult, I agree with that as a pediatric surgeon. When it comes to metabolism and when it comes to growth and development, the children are at even more risk than the adults. And these medications are safe. Certainly they're a hell of a lot safer than being fat or having ADHD. So that's the ethical dilemma that you have to deal with. But you don't have to use these medications if the child and the family are able to change their behavior. But if not, these medications drive that change, correct the insulin resistance, and avoid both the habits and the routines and the rituals that the children entrench that are going to cause disease down the road, and also prevent and reverse certain diseases. It is more criminal in my mind and unethical to treat a child with type 2 diabetes with diabetic medications that slow down the progression of the disease but don't reverse type 2 diabetes than anything I've spoken to about so far. The combination of both. They may need the diabetic medication, but this is the way to go. Before you look at surgery to lose weight, look at changing why they gained the weight in the first place. That, folks, is the ethics, in my opinion, the most ethical way to change your mindset about a child. The challenge is to ignore the ideal practice guidelines that are erroneous. Inflammation, mental health, those are the challenges for these growing children. An adequate substrate provision. And we have to abandon the erroneous best practices that are basically biases against nature if we are going to solve this problem of childhood obesity. But the reversal includes medications, but foundationally, a change in dietary advice and a change in mental health advice. I know that this may sound controversial, but I can assure you we are losing the battle with the current status quo. It ain't working. And this does. I've been in practice for 27 years doing exactly this work now. And every day I see the beneficial results. Why wait until you're 50 and had a heart attack to try to reduce the effect? Start with the children and you never have to deal with this down the road. That's why I call myself the carb addiction doc. If this has made you think, if this has made you reevaluate using logic and using physiology, your ethical boundaries, decide for yourself whether it's more important to uphold what are obviously erroneous best practice guidelines and buck the system to do what's best for your patient. My Hippocratic oath was to my patient, not to some guideline. And I will always do no harm to my children. And the current ethical guidelines are specifically instructions of harm to that child's growth and development. The harm is the existing nutritional and medication best practices. The harm is not what I do with my children every day in my practice. If I've made you think, I've done my job.